across the globe in hysteroscopy and laparoscopy has come us to enrich our knowledge on their respective field. And also we have got a wonderful chairperson, Sanjeev Reddy sir, Srikant Hori, Vijayalakshmi madam, and Sadhana madam, Rakshi Singh, and Vandana Bensan. So without wasting time, as we have started 5 minutes late, we'll be going ahead with our first talk. Before that, we like to hear from our guest of honor, Atul Ganatra, about this webinar and about the topic.
Thank you, Amit, Bessie, Dr. Bakshi, for inviting me, and wish you all a very, very happy New Year and happy Sankranti. I won't waste a lot of time, but I must say one thing about Dr. Paul. 1994, when I got married during my honeymoon, I saw the first operative endoscopy at his hospital on the last day of my honeymoon. My desire to learn endoscopy started that time in 1994, and I think Sir looks the same. He's a giant. I don't need to tell you much about him. I mean, I have learned from him, and I'm sure a lot of people would have learned from him. Welcome, Dr. Paul.
Thank you, Atul. Happy to see you again after a short interval. I'm very happy that all the ISAR organizers, my dear friends, they're all here. So I'm thankful to them for giving me this opportunity. Can I share my screen?
We had to have an introduction by the chairpersons.
Okay. All here.
May I speak?
So I'm thankful to them for giving me this opportunity.
Paul is no...
can I share my screen?
I mean, he's not at all a guest.
We had to have an introduction by the chairperson.
Part of our whole culture of endoscopy, I think, and more than that, and it's a great pleasure. May I speak?
So I'm thankful to them for giving me this opportunity.
Paul is no endometriosis.
Can I share my screen?
That's where he's not at all a
We had to have an introduction by the chairperson.
I wish he would do more and more whole culture of endoscopy, I think, and more than that, and it's a great. May I speak?
So I'm thankful to them for giving me this opportunity.
Paul is no endometriosis.
Can I share my screen?
He's not at all a.
We had to have an introduction by the chairperson.
I wish he would do more and more whole culture of endoscopy, I think, and more than that, and it's a great. May I speak?
So I'm thankful to them for giving me this opportunity.
Paul is no endometriosis.
Can I share my screen?
He's not at all a.
We had to have an introduction by the chairperson.
I wish he would do more and more whole culture of endoscopy, I think, and more than that, and may I speak?
So I'm thankful to them for giving me
Paul is no endometriosis.
Can I share my screen?
He's not at all a.
We had to have an introduction by the chairperson.
I wish he would do more and more whole culture of endoscopy, I think, and more than that, and may I speak?
So I'm thankful to them for giving me
Paul is no endometriosis.
Can I share my screen?
He's not at all a.
We had to have an introduction by the chairperson.
I wish he would do more and more whole culture of endoscopy, I think, and more than that, and may I speak?
So I'm thankful to them for giving me
Paul is no endometriosis.
Can I share my screen?
He's not at all a.
We had to have an introduction by the chairperson.
I wish he would do more and more whole culture of endoscopy, I think, and more than that, and may I speak?
So I'm
Introduction by the chairperson.
More and more whole culture of endoscopy, I think, and more than that, and
Introduction by the chairperson.
culture of endoscopy, I think, and more than that,
Introduction by the chairperson.
culture of endoscopy, I think, and more than that,
The gold standard for diagnosis. In 1985, the gold standard for diagnosis was in 1985, the gold standard for diagnosis was in 1985, the gold standard for diagnosis by the in 1985, the gold standard for diagnosis by the in 1985, the gold standard tool for gynecological diagnosis. And instead of PV, we should do a transvaginal sonography. So we all started, I think in the early 90s itself, I bought one machine myself in my consulting room. And those days, the classical picture of endometrioma was always projected. I remember we were already seeing this type of endometrioma in our practice. And it was that time we could see that Fertility Sterility Journal has many articles on how a classical appearance of ground glass appearance of endometrioma was being diagnosed by sonography. And those days, we tried to make all wonderful diagnosis like kissing ovaries, and we confirm it by laparoscopy. And this was very, we were very thrilled to diagnose all these conditions. This endometrioma looks, there are multiple solid areas, but when I did the laparoscopy and I opened the cyst, it was actually accumulation of hardened chocolate material. And nowadays we know that we put a color flow, we will know that whether it's a papilloma or it's actually a thickened chocolate material itself. We could diagnose bladder endometriosis those days. Is one of my old picture of transabdominal sonography showing bladder endometriosis. And then we used to do the cystoscopy with the same hysteroscope we had. The treatment, all of us know that the first treatment was started by Kistner and Groom, and our senior gynecologist used to say, I am giving Kistner's regime. I never knew that what it is. And this was actually started many, many years back. And it was 1971. The Dinosol was utilized for endometriosis treatment. We all used it in 80s. And a few years later, the GnRH agonist was available. And those days it was called medical oophorectomy. And it was probably Meldrum group who popularized this GnRH treatment. If you look at the treatment, in the early 80s, only way we could do was laparotomy to diagnose endometriosis. And once the laparoscopy came in, we first do a laparoscopy and then followed by Dinosol. Then after 3 months of Dinosol, we used to do a laparotomy, and we call this sandwich therapy. In late 90s, surgical treatment became more popular. And those days, endometrial implants, we used to coagulate with the bipolar, or we ablate with the monopolar. And rarely we used excision for endometrial implants. Endometrioma was little difficult to treat on those days. So some people do a gentle coagulation of the cyst lining. And I still remember in those days, it was a fashion to put some saline into the cyst and then use the bipolar to boil the cyst lining. And I had to do a repeat laparoscopy of one of my patients where I had done in many, many years back. And I found the ovary actually was atrophic on the side because I did a very vigorous boiling of the cyst with the bipolar. And we know that the heat coagulation is using heat is going to destroy the ovarian lining as well as the ovarian follicles, so it should be rarely used. At that time, again, Jack Dones and group said a 3-stage procedure is better. When you have a large endometrioma, you do laparoscopy, aspirate it, then wash it, then give GnRH for 3 months, and then again come back for repeat laparoscopic surgery. But there were very few takers for this 3-stage procedure. Then nowadays we have other alternatives like carbon dioxide laser. Small group of people still perform carbon dioxide laser, which is actually good treatment, but the cost actually is prohibitive for most of the practitioners. Recently, there have been a re-interest in the use of sclerotherapy, where you aspirate the contents of the cyst, then you wash it, and then you put 95% ethanol for 10 minutes, then wash it off. And this is especially used in patients. There was already very low AMH and they were interested in preserving the fertility, or they were planning for IVF. After cystectomy, there were most of the people initial days, they just kept the ovary open. Some people sutured it, but I always like to avoid suturing because we know that suturing causes more adhesions, and we restrict the suturing with just pressure. So this is, we do a cystectomy and we inject vasopressin to reduce, and this is how we started reconstructing the ovary. And I can show you that after a few minutes, 5 minutes, this is how we inject the vasopressin into the cyst lining so that you can have a very thin cyst lining. Sometimes if it goes deep, you have to make sure that you don't take away the whole cyst lining, whole ovarian tissue along with the cyst. All fibrosed areas, thickened areas, when you don't have a cyst lining, then there is no other way you do a flash coagulation without keeping the bipolar steady so that the heat will not be transmitted deeper. If you cannot, the reconstruction again by a bowel grasper is being done, and you can see that without any suturing, the ovary can be lifted. It looks perfectly normal. So I rarely perform a suturing technique for this. Just I had the opportunity to see my own cases. This was in 2012. I did an unmarried girl, a 15-centimeter endometrioma, and we did conservative surgery, right cystectomy, and she had a myoma also, which was also removed. In 10 years later, the patient again came with, she already had 2 children at that time. It was spontaneous conception. Now the uterine size is 16 weeks. So I performed a myomectomy. And to my surprise, you can see the 15-centimeter ovary looks perfectly normal. There is no adhesions. I never used any adhesion barrier. I never sutured. So this is how you follow up your cases, and that give you a fine tuning of your own surgical technique. This is hardly any adhesions. I'll show you another case. This was a 25-year-old, I think she was not conceived at that time. She had bilateral endometrioma. You can see the blackening because the leakage of the chocolate material, and which is covered by the omentum. And I performed conservative surgery. You can see all blackened because of the leakage of the chocolate material all over the uterus and the pelvis. And this is how the reconstructed ovary looked like. And 6 years later, again, she had a recurrence of endometrioma. And you can see that there is very minimal adhesions, and she had conceived spontaneously. The first she did IVF, I think, because many IVF specialists don't have the patience to wait for the spontaneous pregnancy. And the second was a spontaneous pregnancy with this pelvis. And I performed a repeat cystectomy in this case. Those days, people were experimenting how to reduce the dysmenorrhea and pelvic pain in case of endometriosis. And in late 90s, people thought that doing a laparoscopic uterine nerve ablation, dividing the uterosacrals, the nerve plexus will be divided and the pain will be relieved. And soon we found that was a useless procedure, and Luna was abandoned and proven it's not a useful procedure at all. Especially in US, many of the endometrial surgery was actually accompanied by presacral neurectomy if the patient has severe dysmenorrhea, and in those cases, adding presacral neurectomy may be of some use, especially when you are not, the patient has already some amount of adenomyosis. You are not very sure whether your surgery will perfectly, completely reduce the pain. This is the sacral promontory. You divide the peritoneum from the ureter to the mesentery on the left side, and you can identify the presacral neurectomy, presacral nerve plexus. When I started, I thought presacral neurectomy will be a cutting of a nerve, and we expected a nerve to be there, but we know that it's actually not a nerve, it's a plexus of nerve. If you hold it, crumble it, then it would look like a nerve otherwise. And what you do is, over the sacral promontory, you lift up the fatty tissue along with the presacral nerve, you pull up and you take it and you excise. You must look after, there are two dangers. One is you are going very close to the ureter. The second and most frightening thing is, many times the iliac veins may be flattened. You will see as a blue color, and because the veins are always flat, it's not stand out like a artery, and you must take care of. And you know that if your large vein is being damaged, it will be very, very difficult to control. So make sure the iliac veins, sometimes the divided veins may be there, or the main trunk of the vein can be damaged. And once you take out the presacral tissue, we normally take it for a biopsy. So it's you take almost all tissues above the bone, and that's how you decide you have taken out all the nerve plexus. You will identify that. Some amount of the tissue is divided and taken out, mainly for biopsy to confirm that you have taken out the, you can see the sacral promontory below. So all the fat and tissues you hold up without damaging any veins on the sacral surface. And this tissue is divided for biopsy. It's comparatively straightforward if you are careful enough to avoid injury to the vital structures. Those days, classifications, many people try to classify endometriosis according to the grade, and it was Kistner who suggested the first classification of endometriosis: mild, moderate, and severe, very easy, but there was no proper way of telling, because moderate for one surgeon may be different to another surgeon who may think it's a severe endometriosis. And the first American Fertility Society classification had weighted values, and we count the total value and then decide it's mild, moderate, and severe. Later on, it was again modified in 85 and 96, where the scores were given to the peritoneum, the tubes, ovary, and progesterone. We know that the European classification NCN, the main disadvantage, not disadvantage, the main drawback of AFS classification was it did not really correlate with the clinical situation, and it was never any correlation with the fertility or the severity of the disease. That is mainly because deep endometriosis was not included in AFS classification and modifications. So NCN is the European classification where the deep endometriosis was also included. So those who perform deep infiltrating endometriosis are very fond of this NCN classification. I will not go into the details. And recently, AGL classified a new classification. It's actually an extension of AFS where the deep endometriosis was also included. All of you know this. And the score, previously the score used to be very high for a stage 4. Now more than 21 is supposed to be severe stage 4 endometriosis. I already mentioned that AFS classification did not correlate with the future pregnancy. And that's how the new endometriosis fertility index was used along with the grading of the endometriosis. This actually takes into few clinical description. All of us know this, younger patients have a higher chance for pregnancy. So they also take into that account and give a score of 2 or 1. And long-term infertility and short-term infertility, all of us know. Those with short-term infertility have a higher chance for pregnancy. So they give a scoring of 2 if it is less than 2 years. And a previous pregnancy was also added. He thought the previous pregnancy is a better prognosis, but the recent studies did not prove that. And they call it a least function score. All of us know that those days, clinically, we knew that if you had a good tubal anatomy with minimal tube-ovarian relationship, those patients have good prognosis. So this is practically the same thing has been included in the endometriosis fertility index. And we always keep our fertility scoring after the surgery in the case sheet so that we can have some guidance when to how long this patient we should wait for spontaneous pregnancy, when they should be referred for AR. There is one drawback about endometriosis pregnancy research study, that is there is no single RCT on pregnancies following moderate to severe endometriosis. Even now it is not there. Only for mild endometriosis you have a RCT. And recently we looked at our results. Last 10 years we had 150 patients who were planning for pregnancy. Moderate were 50 and severe 101. And we had a very high pregnancy, spontaneous, 72% following moderate endometriosis surgery. And it was 50%, but even then, and almost majority of these patients conceived within 9 to 12 months. So all my young patients, if the male factor is normal, I allow them to have a spontaneous pregnancy and wait for 9 months to 12 months, depending on their inclination and depending on the evaluation, whether any further endometrioma is developing, and we normally wait. But minimum 6 months, I usually wait for almost all patients before submitting for any treatment like IUI, IVF, except when the male factor is compromised. These were the pregnancy results, which I already mentioned. Is a spontaneous. 83% were spontaneous pregnancies, and only a small percentage were IVF, because I normally perform IVF slightly later, wait for some more time. There is a lot of aggressive surgeries going on nowadays. People think that any endometriosis should be excised, whether it's on the rectum or it's in the nerve, everywhere, whether they are symptomatic or not. So this era, people are more aggressive because they have more skills, and they do a peritonectomy for many patients, which I personally believe it's not needed. Only the implants or deep endometriosis should be excised. Bowel endometriosis should be operated only if they are symptomatic or any definite. Just because there is a nodule, we should not, because all of us know the potential major complications like a leak of anastomosis, which happens 10 to 15% in expert hands. So all youngsters are getting into, I know about personal stories of many people have gone into getting into trouble because of, and once you get a complication, it's not very simple to treat. Urinary tract endometriosis is comparatively common. Majority of the endometrioma patients do have ureteric endometriosis, and if there is hydronephrosis or compression, definitely you should do a ureterolysis and isolate the ureter. I initially believed that endometriosis is very rarely go for malignancy. But once I came across few cases, this is one case done few years back. She had already a child. She had a bilateral multiloculated endometrioma. So this is how it looked like. There were a lot of surface implants, and the appendix was adherent to the right pelvic side wall, and you can see it's involved in the POD. And there were the uterosacrals were affected. I did not do any very aggressive excision of the uterosacrals. Only the scarred area I isolated and excised. Definitely, the retroflexion of the uterus is being corrected. We normally inject vasopressin on the uterus for this sharp dissection, and we perform the cystectomy. And if you have multilocular endometrioma, you should open up all the endometriomas in the beginning itself so that you will not miss. That is the one cause for early recurrence of endometrioma, because you miss few of them, and this is how you just reconstruct. The second was enucleated. Again, it was appendicectomy was also done. This is the final picture. But the biopsy came as the left endometrioma had focal atypia. We took a second opinion before taking any aggressive treatment, and they advised she can try for conception and then perform an adnexectomy after pregnancy. She conceived spontaneously, and we performed an adnexectomy after delivery around 6 to 8 months later. This is a 42-year-old. She already had lap surgery for endometriosis 2005, 2006, and we planned for laparoscopic hysterectomy. But here you can see there is a small solid area in one of the ovaries, and we performed a laparoscopic hysterectomy, and the left ovary had the left ureter was isolated, and we removed the ovary after the hysterectomy was performed. It was definitely adherent to the pelvis, and you can see that there is a solid tissue inside this cyst. We performed adnexectomy. And this was the N picture, the biopsy came as clear cell carcinoma. This was a proven endometriosis, and she had this conservative surgery twice. So I sent it to my old student, Dr. Anugoma, to the oncology center, and they performed a repeat staging procedure. The pelvis was reasonably okay, except some adhesion on the side where I think they performed a sentinel node biopsy. Actually, they were all claimed to be, they took sentinel biopsy. She performed robotic surgery. They did a omentectomy. I think she removed the specimen through the laparoscope. So I just tabulated my endometriosis series, almost 1,000 cases I looked at, and I had 14 cases of atypical endometriosis. 3 had a borderline pathology, and 2 were clear cell carcinoma. There were 2 cases of endometrioid, and 1 case there was borderline plus carcinoma in these cases. So all of us know that atypical endometriosis is a pre-neoplastic condition, and they should be treated as long as the childbearing function is over. And these are the common carcinomas we saw, clear cell and endometrioid carcinoma. And if you look at the lifetime probability of not developing malignancy is, as far as endometriosis patient is concerned, 98% of them will not have a malignancy against 99% for a normal group. So endometriosis, without doing any surgery, prolonging, and if any doubtful situation, and if you have any clinical scenario which suggests a potential for malignancy, which is there actually, we should intervene, and medical treatment, lifelong medical treatment is not a good option. That's what I gathered from my practice. I also looked at any new theories about the pathogenesis, pathophysiology of endometriosis. This was AGL publication where they checked 34,000 PubMed public index journals, and majority were published in 90s. Sorry, in late 80s. And they wanted to find out any pathogenesis or any etiological factor could be discovered. So all of us know that we have a lot of genetic tools like microarray, metabolomics, metagenomics, next-gen sequencing, single-cell technology, and a lot of studies have been done. And this genome-wide association studies could identify there are 42 loci predisposing women to endometriosis. But they could explain only 2%. So the genetics, epigenetics can explain only a very small percentage as an etiological factor for endometriosis. Role of infection, because we all heard how we knew that we all did during my house surgeoncy days, any major surgery list will be 2 or 3 cases of GJ vagotomy, another sympathectomy. Both surgeries have become now obsolete, and now we know it was the Helicobacter pylori responsible for peptic ulcer, and we treated them. A medical condition was treated by surgically. Now I think none of our new surgeons know how to perform a GJ vagotomy. So again, we know when we all were studying in college, we never knew that it was an HPV responsible for CS cervix. So role of infection is a possibility, only thing we don't know whether we have it. Again, we know that the microbiome is responsible for many of the diseases, and we know that our body contains same number of human cells as like microorganisms. So probably a microbiome change may be one reason for endometriosis, but we don't know. Still, we don't have any. Then regarding the diagnostic modalities, we are still in the old, our ultrasound, laparoscopy, MRI, that's all. But recently, there have been few studies based on microRNA, and they could diagnose with the salivary microRNA. I think Dr. Remedy from Trichy, she had a similar study with the blood of microRNA. So probably it is going to be little more easier. Unnecessary laparoscopies can be avoided, because if this gives you an idea that this girl is suffering from endometriosis, and probably help in the management. There is a new modality is being publicized. It's called EndoSure. I think it's licensed in UK and Europe. What they do is they do measure the myoelectrical activity of the abdomen. They put electrodes on the abdomen, and usually the patient has to drink around half a liter or 800 ml of water, and they monitor this in the after drinking so much water, as well as in the fasting level. And by AI, artificial intelligence, they compare this data with the patients who don't have endometriosis, and they are trying to diagnose this. And a few studies recently have shown that this is almost 100% accuracy in diagnosing endometriosis, and also it is supposed to stage the disease with this value. The main principle I already mentioned, that it is the prostaglandin release which causes abnormal intestine motility, and electrical activity of that motility is being measured, and they have found out a particular frequency electric activity, and then it is an algorithm by the artificial intelligence is being used to finally diagnose this. Probably it's going to come and a simpler procedure. Now, regarding the treatment, do we have any major advances in the management of endometriosis medically? If you just look at the malignancy, almost 100 new drugs have come since 1990. But what about endometriosis? We have the same GnRH agonist, Dynogest. Now we have antagonists, and our treatment is still symptomatic therapies, and all based on inducing amenorrhea. There is no proper drug. Without amenorrhea, you will get some medical benefit. So as far as the treatment is concerned, we are very, very slow as far as endometriosis is concerned. But we hope before we die, there will be some medical treatment. It should be where surgery will become obsolete. So the treatment since 1990, now 35 years or 40 years, there is no dramatic or major change in the management of endometriosis, which I have been a part observing all this changes going through. Will surgery become obsolete? We know that many surgeries, when I started, there was a lot of surgeries for round ligament plication, for diverting the uterus, then ventral suspension. Then we used to do tubal implantation for cornual blocks that has gone out. GJ vagotomy has gone out. And many surgeries in front of my practice has disappeared. So one day surgery for endometriosis can also disappear. But the basic question somebody has put is, why does endometriosis affect some women? Why does it progress in only some? Because I showed you in some case few scenarios where there was no endometriosis even after 10 years, but we know that there are few patients will get an early recurrence. We don't know the reason. We should know, then it will become easier to treat. So to conclude, endometriosis is still an enigmatic disease. Is the incidence increasing? I think we are in a peak now. All over India, everybody is talking about endometriosis. 20 years back, mostly from Mumbai, from Cochin, Kerala, we had presentations on endometriosis. So there was a change. Probably we have peaked, and hereafter it may remain same. And no breakthrough has happened as far as endometriosis is concerned, as well as for the diagnosis, for the treatment part. A lot of research is going out throughout the world, and we hope we are getting close to simpler diagnostic modalities, and there will be a day where a medical cure or prevention is going to come for endometriosis. Thank you all for the patient attention.
Thank you, Paul sir, for that excellent insight into the evolution of the endometriosis, right from the initial concepts to present concepts. And before handing over to chairperson, let me have a word about the chairpersons. Sanjeev Reddy sir is the HOD, Department of Reproductive Medicine, Surgery, SRMC, Chennai, with 30 years experience in field of obstetrics and gynecology. And we have Vijayalakshmi Pilla madam, who is the Chief Gynecologist, Obstetrician and Laparoscopy Surgeon and Medical Director of Vijayalakshmi Medical Center. And also we have Srikanth Dohri. Anu, just introduce.
Yes.
He's
Dr. Srikanth is a young budding gynecologist from Varanasi. He's an excellent laparoscopic surgeon. He has done fellowship in gynae lap surgery from Israel. And he's course trainer at Foxy approved New Life Advanced Laparoscopic Center, Varanasi.
So over to chairpersons for the session. Same.
Okay. Dr. Paul sir, it's very nicely explained your experience from the beginning, 90s to now. Many times you are telling they conceived spontaneously, many patients. Do you have any statistics stage by how was your pregnancy rate?
Yes, Dr. Sanjeev, I showed you the slide. This is only moderate to severe endometriosis. I did not include the mild one. And according to that stage, I am trying to publish a paper on the same data with the EFI scoring. So I am trying to do EFI scoring retrospectively by looking at all those pictures. And it's almost ready. Only thing is the present conclusion about the EFI score is not really correlating well in my studies. Otherwise, what I quoted was only moderate and severe, where we don't have any RCTs. There are only few studies on this, moderate to severe endometriosis, the pregnancies. I told you, 80% was spontaneous, only 20%, but that depends on each center, your inclination for doing an early IVF.
Okay. Another thing is when you are doing the endometriotic surgery, particularly those who wants to become pregnant, our main concern as a reproductive medicine specialist, ovarian reserve. Can you give us some tips how to save the reserve, decrease the damage to the reserve, ovarian reserve?
I am also very concerned because I find many younger surgeons, they do a lot of surgery for retroperitoneal surgery very nicely. But when they come to the ovary, they are little impatient. They do it as the last step of the procedure. I told you, most of the reason why we lose more ovarian tissue is the one who have multiloculi and all those with very small endometrioma. Very small endometrioma, you will not get a layer. Already endometrioma does not have a real cyst lining. It's actually a thickened pseudocapsule. So when we remove, we must reduce the thickness. I always send the biopsy and I talk to the pathologist whether how much ovarian tissue was present on the specimen. That's how I take a lot of feedback and I spend a lot of time. I do very slowly and remove all the loculi if possible, but with the minimal loss. That's
Many
how
times that cyst wall will be stuck firmly. It is not easily, we are not able to make out. Can you give some tips how to proceed here?
Very small ones usually do not have a cyst lining. So sometimes I use the scissors to very nicely, and occasional areas you probably just coagulate superficially. There is no definite layer, but injecting vasopressin into the correct layer can reduce loss of tissue because that fluid layer will give you how much ovarian tissue you can keep it on the ovarian side when you do the enucleation.
Above which size you will advise surgery in your experience?
Mostly a patient symptom. Second is unless it's 4 or 5 centimeter, I normally operate immediately. It should be ideally delayed unless there is a clear indication for surgery.
Okay. Madam Vijayalakshmi, madam, you can ask some things.
Yeah,
Any questions are there?
Yes, there is a question from Dr. Nakul Patil. He is asked regarding spontaneous pregnancy in your moderate and severe endometriosis operated cases, what was the AMH and AFC post-surgery in these cases and what was the age group? Of course, you have given the age group statistics. That's good, but he has asked what was the AMH and AFC if you have ever scored it and kept it.
No, it was AMH was now it's a routine preoperatively and postoperatively we do, but majority of my series is before that era where AMH was freely available, so I did not have and the AFC count we do only for those patients with for IVF.
Sir, medical legally is it important to do when you do that big endometrioma or bilateral endometrioma to do the pre-op AMH level in future?
Now it is important because that yourself, you give an idea how much it was. Otherwise, immediately afterwards, you go for IVF, they do the AMH repeat and they find it's very low, then probably you are a culprit. But till now, we never had any. But usually, if the surgeon and the aortic specialists are different, definitely there will be a blame on the surgeons regarding the surgical technique.
I have two questions to ask Dr. Paul. One, if you see deep infiltrating endometriosis in a patient with infertility and endometrioma and endometriosis, pelvic endometriosis, would you care to operate on deep infiltrating endometriosis along with the same thing? Or would you care to leave it? Because infertility is the...
No, I don't leave any major disease.
Okay.
But I will not be aggressive.
Okay.
For example, if there is some implants on the rectum, I remove safely what safely I can do. All surgeons have their own confidence, know what level you can perform this. But if there is no symptom, I will be less aggressive on deep infiltrating endometriosis.
Question number 2. How many times do you think a reoperation in endometriosis has harmed or helped the patient?
No, many patients do come back with cysts bigger than she had originally and with severe symptoms, sometimes infection. So depending on the patients, any surgeon will reluctant to operate on a previously operated endometriosis, but if the situation demands, you have no option. I have done after 3-4 surgeries also I have done, and majority we will advise them for hysterectomy, but many still will not have a child and they may not be agreeing. So depending on the patient's inclination and symptoms, we will operate.
This is ovarian endometriosis or peritoneal endometriosis you are operating 3 or 4 times?
No, mostly ovarian. Mostly ovarian and deep infiltrating endometriosis also.
And any more questions?
With the permission of chair, yes, with the permission of chair, can I ask 1 or 2 questions to Dr. Pal?
Of course.
Yes. So excellent presentation. It was very treat to listen. 1 or 2 points which you said very beautifully, that what has happened, infection, microbiome. I will like to have your opinion about a real environmental toxin and especially the use of suddenly excessive use of diapers in the childhood. And do you think that it is something contributing to poor reproductive health to male as well as the female, including endometriosis? And the second question is, do you consider that the ovarian endometrioma and deep infiltrating endometriosis, they simply behave different way? One is like locally malignant, need difficult to have surgery but need surgery, and endometrioma and the what you said, the clear tumor, borderline tumor, for which the Indian population is more prone, and DIE, which is the Western population, is more prone. So in your experience, what's your like a wise input about that, how to deal with the 2 different kind of endometriosis?
That's a valid thing. All of us know that. I will answer the last one. When we see all foreign faculties, their videos, mostly they are operating on deep endometriosis. Their ovaries will be perfectly normal, tubes will be normal, only POD is obliterated and they are trying to do the excision. But we have predominantly peritoneal and ovarian endometriosis, definitely coinciding with there is deep infiltrating endometriosis. Purely deep infiltrating endometriosis is very, very uncommon in my practice. I have never seen any woman without peritoneal or ovarian endometriosis. Then the environmental toxins, a lot of things have been implicated, but we don't have real proof. But a lot of epigenetic changes are possible. But one thing I personally believe is, if I look at my grandmother, she might have ovulated only 40 times in their lifetime, whereas a modern girl do menstruation 400 times. So 10 times menstruation, and the menstrual overload definitely is one reason. And all of us know that now we have early menarche, late menopause. So this have some correlation. That's what I think.
Hello.
Dr.
Can I
Srikanth?
ask one question?
Yes.
Hello.
Yes,
Hello,
Dr.
Dr.
Vandana.
Paul.
Yes.
Yeah. So actually, excellent presentation, Dr. Paul. I have one question. I have seen that if the pouch of Douglas is obliterated, then the result in IVF is very low. So what do you think in deep endometriosis? Will you always clear the pouch of Douglas while operating? And is it important?
Vandana, I am not very sure. The many studies and to my knowledge also,
Okay.
POD obliteration does not actually reduce the infertility as much as the peritoneal and ovarian. But definitely, as you said, if the patient is symptomatic, definitely I will hand the POD endometriosis. I never leave any endometriosis, but as far as safely I can perform without injuring the bowel or any organ, I try to remove the endometriosis if I am doing a surgery.
So do you think that while we are operating and the patient is for IVF, so will you clear the pouch of Douglas always, or will you leave it?
I never leave it,
Yeah,
especially if the
that is
patient
what.
is symptomatic. I never leave it
So
because many of my patients expect me to clear her
clear,
endometriosis.
yeah. So
So
I think it is
I
important,
oblige.
although very few papers are there on this particular thing, but I think it is important to, as far as possible, the pouch of Douglas to make it clear while the patient, you think is you're going for IVF. Thank you very much, Dr. Paul.
One more question is there, if I don't mind to take it. That is from Dr. Preeti Kora from Kolkata. In perimenopausal women with ovarian endometrioma over the size 5 centimeters, but asymptomatic, do you advise surgery or follow-up scan? Perimenopausal woman, size 5 centimeters,
She's
over size 5
symptomatic,
centimeters.
symptomatic or
Symptomatic.
Asymptomatic.
asymptomatic. Definitely you can watch and see whether it's enlarging or she become symptomatic. Otherwise, immediately I will not venture into surgery immediately.
Okay.
Dr. Srikanth, we didn't hear from you. Dr. Srikanth, do you have any question?
I think he is not here. Dr. Srikanth? So should we
Maybe
move
it's
to
not
our
there.
next session?
Yes,
I
yes.
think we should move on. Thank you so much, for Dr. Paul, and thank you all the whosoever asked questions. Dr. Paul, thank you again. And it was
Thank you very
wonderful.
much for giving me this opportunity. My friend Osama is ready, so I am stopping my lecture. Thank you.
Okay.
Thanks,
So-
sir. Dr. Fessy, please.
Next session, we have Dr. Osama Shauki has already joined. Before that, we will introduce the chairperson. They will introduce the speaker. And we have for this session, Dr. Sadhana Gupta. Madam is the ICOG Vice Chairperson elect 2025. And with special interest in academic and social writing, high-risk pregnancy, advanced infertility, osteo and promotive medicine. She doesn't need introduction. She is so famous all over India. Next, we have Dr. Aki Singh. She is the president of the Noida Society, Governing Council member of ICOG, Vice Chairperson UP Chapter ISAR, and peer reviewer of Jogi, was the chairperson and technology committee of Oxy 2023.
Thank you, sir.
Next, we have Dr. Vandana Bensal. She is IVF specialist and laparoscopy surgeon and cosmetic and aesthetic surgeon. From the gold medalist from Allahabad University, established Eastern UP's first state-of-art IVF unit, ARPIT, and organizing chairman of many conferences and president-elect of ISAR Prayag unit, president-elect of AOGS Pragyaj, and invited faculty of various conferences. Over to chairpersons to introduce the speaker. Our most world-famous laparoscopy, hysteroscopy surgeon, Osama Shauki.
So,
Over to chairperson.
Let me do the honors. First of all, thank you, Anu Fessy, for this invite, and it is a really wonderful session. So, Dr. Osama Shauki, she is a very, very well-known face, and Dr. Sharma, we will, after the end of your talk, we will like to say there are many such, but how stars are evolved, it is your secret. Everybody is having, like, whenever you are there, there is a large crowd around you, and we really want to wish to listen your all of the level of the remarks and all the things. So he's a very well-known endoscopic surgeon. Special interest he has got in the hysteroscopy, and I think he's the first person who talked about the vaginoscopy right from the beginning. Surgeon at Shifa Hospital, Egypt, director of Aptissima Center for Advanced Endoscopic Surgery at Egypt, director of Hysteroscopy Academy for Research and Training, board member of International Society Gynecological Endoscopy, editor of European Journal of Gynecological Surgery, and he is a very well-known figure. He has invented many, many instruments which we have in our OTs, and always have thought beyond box and out of the box. So a warm welcome, Dr. Oshama. And today is Makar Sankranti, when the sun goes into the different field, and it is a auspicious day that we are having such two legends, and we are here with you in the virtually and learning a lot from everyone. Thank you very much. So welcome, Dr. Oshama. We all are eager to listen to you.
Oh,
Dr. Osama.
hello everybody. Namaste. Do you hear me?
Yes, sir. Namaste. We can hear you, sir.
Oh, what a lovely smile, Rekha. It's lovely to see all my friends online, you know. My heart is beating strongly that I want to jump and come and...
Welcome.
Well, despite the distance between us, thousands of miles, but I can feel your heart rate. And I'm happy to see beautiful faces of my friends, PG Paul, Fesi, Anu, and Dr. Sadhana, everybody. Well, so let me start, and I will not say I'm giving a lecture. I'm going to entertain you by some interesting insight about the role of hysteroscopy in modern gynecology. Can I share my screen now?
Yes, sir.
Okay, share. Please, at any moment, if you don't see my screen, let me know, okay?
Okay, okay.
Mr. Nakul Patel, all right? If at any moment, all right. So, let us start the entertainment. Today, I'm going to join you in a journey about wonders of hysteroscopy. And today, I'm going to invite all of you to my home. Actually, it is the home of each and every one of you. Each and every one have enjoyed 9 months full board accommodation inside this cavity. Well, I have to confess a secret for you that hysteroscopy changed all my life. I started as a laparoscopic surgeon in the beginning with all my friends, Hafiz, Rakesh Sina, Prakash Trivedi, PG Paul. We all started playing with the laparoscope inside the abdomen. But by time I realized that the real home is the cavity of the uterus. Most of women health issues, whether related to fertility or related to bleeding, is from inside the cavity. Definitely endometriosis is coming outside, but I could see wonders inside the cavity. I traveled 69 countries all over the world teaching and operating, but the most visited country in my life was India. You see how many visits I have done? 168 training programs, more than 3,000 challenges, operations, hands-on training for more than 5,000 gynecologists. So I traveled each and every small city in India. I traveled by all airlines, spicy, non-spicy, Go, Indigo, in every corner of India. And my unique teaching technique depends on hands-on. You have to take the feeling from my hand. My dear friends, understand what I say. You can learn laparoscopy. You can learn open surgery by watching the expert because you can see his hands movement. But hysteroscopy is different. Hysteroscopy, you cannot see the movement. It's very, very little movement. So unless you get it from the feelings of the hands of the expert, you'll never learn it. So that was my new approach, spreading hysteroscopy by teaching everyone, holding their hands, hand on hand, to give the neuromuscular coordination. And I'm proud of all my students. And all over India, everybody now is super expert in hysteroscopy. And I'm always proud of showing this letter communication with His Highness Minister Narendra Modi, and appreciation for the outstanding surgical facilities and the training program I have done. So probably I did a good job in your country. Today, let me take you in a journey inside the cavity, starting by congenital uterine anomalies. Is it common? Yes. Yes. Look at this systematic review about the prevalence of congenital uterine anomalies in population. You will be astonished that this study conducted on 86,000 women. 86,000. They found that uterine septum and anomalies exist in almost 13% of infertile ladies. 13%. And the incidence jumped higher in patients with recurrent pregnancy loss. 24%. Can you imagine, Fessi? 24% of patients with recurrent pregnancy loss, they have a problem, congenital anomaly inside the. If you look at the population of India, okay, you are almost 1 billion. Half of them are women, which is 500 million, okay? Half of them are in the childbearing group, which is 25 million. So if we are talking about 10% of quarter of a billion, this is 25 million women in your country has a problem inside the uterus. So it is not rare. It is not rare. So this is the latest classification adopted by the ESHRI and the European Society of Endoscopy, which is now accepted as a standard for classification. They put 0 for the normal. So U0 means normal uterus. U1 is a dysmorphic uterus. This means abnormal, morph means shape. So dysmorphic, which means abnormal shape uterus, this is the U1, which entails the T shape and the infantile uterus. And when we come to U2, remember, like YouTube, okay, U2, this is the commonest anomaly which you require to treat, and I'm sure everyone in the assisted reproduction business should know how to diagnose and how to treat the septate uterus, the U2. When both corneas are separate, this is the bicornuate uterus, U3, and then U4 is the unicornuate uterus, which is with or without rudimentary wall. Actually, the classification does not stop only for the uterus, my dear Fessi. It also applied for the cervix and the vagina with the same numeric. 0 is the normal. So C0 is the normal cervix. C1 is the septate cervix. C2 is a double cervix. Understand? C1 is one cervix divided by septum, right? C2 double cervix. Actually, this is how it looks by naked eye appearance. This is a cervix with 2 openings. It's a septate cervix. This is 2 separate cervixes. The diagnosis basically is by MRI or 3D ultrasound. And then we have C3 is unilateral cervical aplasia. C4, there is no cervix, cervical aplasia. The same for the vagina, V0, V1, V2, and this is the V1 longitudinal vaginal septum that will also meet in infertility. It causes dyspareunia or aparunia, and the septum extends all the way till the uterus. We're gonna discuss this later. Okay. Let us, because you are this webinar focused on fertility, let us see how far these anomalies may affect fertility and what are image of T-shaped uterus. Diagnosis of T-shaped uterus is by hysterography or more accurate by 3D. So, Fessi, this is a T-shape. What's your opinion? I want to hear your voice. What kind of anomaly is this?
I think it is I mean, as you told, the cavity size is less T-shaped.
Okay, so this is a classic T-shape. In this one, there is a fundal cupping, like a short septum. So this is Y-shaped uterus. So the new classification now added to the T-shape, there are 3 varieties: T-shape, Y-shape, and I-shape. They are all U1 anomaly. Okay, so as I said, ultrasound diagnosis is the corner stem. And this publication by expert sonographer about congenital uterine malformations by expert, and they put the criteria for the diagnosis of a T-shaped uterus. Because we cannot depend on personal opinion. Maybe I say, it's a T-shape, And then Fessi said, no, Osama, it is a rather small cavity. So we have to put a standards for diagnosis, okay? So at ultrasound, you measure this lateral angle. This lateral angle should be less than 130 degree, okay? And then the thickness of the lateral wall, they call it the lateral depth. And this should be by an expert sonographer. So this depth should be more than 7 millimeters. And by the way, Fessi, when we have increase in the lateral depth, this will compress on the uterine cavity. That's why you have a tubular shaped cavity. When the lateral wall hypertrophied, the cavity is compressed. So again, the lateral angle is less than 130, the lateral depth more than 7 millimeters, and this is the T angle, okay? It should be less than 40 degrees. So please, my friends, don't depend on yourself. I know that you're all gynecologists, you can do ultrasound, but it should be done by an expert. And look at the title of the article: Congenital Uterine Malformation by Expert, QME study, all right? So, Osama, you are a hysteroscopist, and we are also do hysteroscopy. Can we diagnose a T-shape at hysteroscopy? It's subjective, okay? It depends on how expert you are, all right? But there are certain signs I can tell you. Listen, my friend, Dr. Anu, when you do hysteroscopy, please don't go quickly by the telescope, okay? You go from external os, push fluid to open the cervical canal, just approach the internal os and stop. Don't use the hysteroscope as a Heger dilator, okay? You stand at the internal os and stop, and then have a look in front of you. In normal uterus, here in this view, I'm standing at the level of the internal os. In normal uterus, you can see the fundus. You can have a glimpse of both tubal ostia because the lateral wall are divergent. You got my point? But in T-shaped uterus, you have a tubular cavity. You cannot see the tubal ostia. So this is an added way or added tool for diagnosis of a T-shaped uterus. So what is the solution? Before we go to the solution, let us ask the literature. Does T-shape affect fertility? Does correction of T-shape will add solutions and success for pregnancy? Yes. This article was in Fertility and Sterility a couple of years ago. And this is all my team and my friends, Dr. Luis Alonso from Spain, Antonio and Simone from Italy. Well, they conducted a study on 63 women with a T-shaped uterus, okay? Hysteroscopic correction was done. They were all infertile. 63 infertile T-shaped uterus. After hysteroscopic correction, metroplasty, pregnancy rate was 83%. And the live pregnancy was 63%. So this article draw the line that yes, hysteroscopic correction will improve the pregnancy. Let me share with you a beautiful procedure I have done for a Y-shaped uterus. So, Fessi, here you have like a short septum, and here you have a tubular cavity. So the procedure is to cut into the fundus, to elevate the fundus, to remove the fundal cupping. So you do expansion on this direction, kifal, and to do lateral cut to resume the V-shaped cavity. The normal cavity is V-shaped. So how much we cut here? It's very difficult. If you cut too much and you perforate, you will hit the uterine artery. If you are very hesitant and take little cuts, still the cavity is narrow. So a preoperative ultrasound is a must. A preoperative ultrasound to measure the lateral wall thickness. So you know how much to cut, all right? Then we come to the next question. Okay, Osama, ultrasound can measure the thickness by a cursor, but inside the uterus, how can you measure the distance you have cut? I will tell you the secret. Let us enjoy the procedure. This is a Y-shaped uterus. This is the fundus. It's like a short septum. Cut. So the tubal ostium is your landmark. Both ostia is your landmark. So you cut into the fundus till reaching a level of both tubal ostia at the same line. Okay. So people always ask me, Osama, what is this white color of tissue? This is the fundal muscles. Please understand, we have to correct the wrong belief that septum is fibrous tissue. Septum is muscles. Look how to play with the scissors. And this is the tubal ostium here. Fessi, listen to me, Fessi. Scissors is not only to cut. Scissors is to feel. You understand? Feel. And then try to get the feeling of the consistency of the tissue, and then push and then cut. So here I am feeling this is the tubal ostium. Why the tissues looks white? Why there is no bleeding? There is no bleeding because of the effect of fluid pressure. You have to increase the pressure to tamponate the bleeder. So, I need more time to say how to use the scissors. In laparoscopy, you move the scissor like that. This is laparoscopy. In hysteroscopy, you cannot do like that. In hysteroscopy, no. In hysteroscopy, you rotate. Rotate. If you want to forget all my lecture, remember only this thing. Scissor movement is rotation, not side to side. Okay? And now we're going to the lateral wall. So, my dear friend, Dr. Sanjeeva, Dr. Reddy, how to know the distance that I did cut? I don't have a measuring scale, but listen, when you open the scissor blades, this is 3 millimeters, okay? So use the scissor blades as a measuring scale to know how much you cut. This is one lateral wall, and then we go to the other lateral wall.
Okay.
You look at the blades of the scissors. When you open the blade, this is 3 millimeters. So here I almost cut like 3 to 4 millimeters. 3 millimeter, 4 millimeter right, 4 millimeter left. And then assessment of the cavity. How to assess? You pull back and have a look at this view. Now you can see the tubal ostium. Appreciate that. Now you can see the tubal ostium. You did lateral expansion, fundal expansion, and we have a beautiful cavity. The post-operative judgment is by repeat again the hysterography to check and differentiate between before surgery and this is after surgery. Now we have a beautiful cavity. Then you can go for spontaneous pregnancy or even for IVF. So bullet information or advice, T-shaped uterus should be corrected by the most expert hand and try to avoid electrocautery. I can accept it, but try to do it by scissors, because if you do electrocautery, that burns the endometrium and post-operative adhesion might happen. Now, let's move to another anomaly, the unicornate uterus, a banana-shaped uterus. Another reason for recurrent pregnancy loss, abortion, and infertility. Is correction of a unicornate uterus valuable or valueless? Another study conducted on 326 infertile women with a unicorn. This is the evidence, my friend. Here is the evidence. So this study showed that women with a unicornate uterus has a significant lower pregnancy and birth rate and a higher rate of miscarriage. And correction of unicornate uterus increased the pregnancy rate. The surgical correction, same like we have done in the T-shape, we do lateral incision to expand the cavity and allow more size to accommodate for pregnancy. Let me share with you this case. This is a unicornate uterus. You can see only one tubal ostium. You do lateral incision using the blades as a measuring scale. And you stop at the level of the ostium. Here you can see a beautiful, this case was done in Rainbow Hospital with Dr. Narendra Malhotra. And this patient, she had infertility for 6 years. And we did bilateral expansion, tubal ostium at the center. And actually, it was the first case that we try in India, the technique of PRP. Look, Fessi, I want to show you something. This is, you see, the patient has very less endometrium and a new surface area. So to enhance the regeneration and growth of the endometrium, we inject PRP subendometrial. There is a lot of controversy. Not everybody agree upon that, but definitely everybody agree that PRP is valuable in cosmetic, for the face, for the skin, for the hair. So why not for the endometrium? So this patient, my evidence is Dr. Narendra Malhotra, who have informed me the patient got pregnant after the hysteroscopy without the need of IVF. And now, after finishing the T-shape and the unicornate, let's go to the most controversial anomaly. There is no issue in gynecology received such debate, fights, controversy like the uterine septum. Some people insist to treat. Many people say no need for treat, like the TRUST study, and even the fight about how to treat. This image of the Bugs Bunny ear is very classic for a uterine anomaly, but you cannot be sure, is it a septum or didelphys? So please, Fessi, never depend on hysterography for the diagnosis. You should do 3D ultrasound. This picture is a $1 million picture, okay? There is a lot of teaching about this picture. Listen, my friends. At a proper 3D, you have to identify the following points. And I always teach that septum surgery require, in my hand, 7 minutes. But before surgery, I spend half an hour to study this image. You have to study the map before driving the car. If I study the map, you can drive quickly and finish. So now appreciate what I say. At this image, you have to see the level of the fundus. Here is the fundus, okay? Then a line between both tubal ostia, interosseal line. So this is the interosseal line, and this is the level of the fundus. The distance, this Y, is the fundal thickness. You know, this is very important, Fessi. You have to measure the fundal thickness. Because in your attempt to do surgery, when you cut, if you exceed the interosseal line, you are cutting into the fundal myometrium. Yes, maybe you will not perforate. You will not perforate, but you are decreasing the thickness of the fundus, and this patient will get ruptured uterus during pregnancy. So, first landmark, this 4 or 5 landmarks, every surgeon doing septum should know by heart. The line of the fundus, interosseal line, apex of the septum, internal os. Okay? You have to know this information quite well. Another dangerous sign, Fessi. Some cases, there are fundal notch here. It's a combination of a septum with a bicoordinate notch. If you're not aware about this, and you are cutting the septum all the way up, your aim is to reach interosseal line. If there is a notch, you'll perforate here. I hope this valuable information will be a good support for you. Let us now see how to correct the septum, either by the scissors or resectoscope. Sorry. I will start by the scissors. This is the panoramic view. Look at both tubal ostia, because the tubal ostia is your landmark. And the septum is here. So you want to cut from here, reaching all the way up until both tubal ostia at the same level. Enjoy that. Scissors. Cut. Cut. Cut and pull back. Cut and pull back. And let's forever be tonight. I want my audience not only to enjoy watching, I want you to feel. You understand? Feel by your heart how the scissor move, how the scissor rotate, how the scissor feel and cut. When we're together, I'm in a dream. Cut. Many times I've whispered. Tubal ostium is your landmark. Here, this is the tubal ostium. It's just a picture that I heard in place. I was acting a part. But now when I whisper, now you do assessment. If this is enough, no. There are some fibers here. It is a plastic surgery. I want you to see how to cut. At this moment, you are near the fundus. Take little bites, little bites, little bites to finish a straight line. Look how to use the scissor. Look, Fessi, how to rotate the scissor. And this is the final view. Now, another option is the electrocautery. Monopolar or bipolar. Distend the uterus, stretch the septum, and cut. Never push. No pushing. Huh? Fessi, no pushing. Move the electrode, and you can see the electrode and the tissue retract. Tubal ostium. Look at the tubal ostium. This is your landmark. Here is the tubal ostium. Look at that. And this is now the final view. Final view. Both tubal ostia at the same line. Both ostia at the same line. Septum is completely removed. And now, post-operative. This is before, and this is after. Well, the question now, should we treat the septum or no? There was a randomized study called the TRUST study, which came by a very abnormal or astonishing conclusion that there is no need to treat the septum. This study called the TRUST study, if you hear about it, and then it was realized that the methodology of the study was very wrong. I am sorry to say that the people who did the septum surgery in the study were purely IVF people. They were not surgeons. Many of the cases operated upon, they had a perforation, bleeding, incomplete removal. So that's why the results that treating the septum add more damage, right? But other literature proved that correction of the septum will definitely give a higher pregnancy rate. I want to share with you another wonder about endoscopic vaginal surgery. We know that laparoscopy inside the abdomen, hysteroscopy inside the uterus. What about inside the vagina? Here, a case of a vaginal septum, and this is the classic surgical technique. You put two retractors, and the bladder is in front. You can injure the bladder, you can injure the rectum. I don't like this technique. It's my pleasure to introduce an innovative technique that I developed for treating a vaginal cervical uterine septum, all the way from down up. So enjoy this procedure, but you have to achieve good distension of the vagina. By closure of the vaginal introitus, now we are inside the vagina. Look at the beautiful part. This is one cervix, one external os. Pull back, pull back. This is, now you can see the septum. This is a beautiful view, beautiful. Never better, never. So no need to put retractors, okay? So you go by the resectoscope and cut. This is unification of both hemivagina. It's a beautiful technique. I'm very proud to introduce a new concept, which is intravaginal endoscopic excision. We can remove so many pathology. I have did a case of vaginal fibroid even. Now cutting, you see, unification. Now we remove the vaginal septum, going cephalic all the way up. And again, Fessi, this is not two cervix. There are two openings, two external os, but this is one cervix. You will see now, this is one opening, and this is the other, okay? So don't worry, Fessi, because I have an MRI telling me it is one cervix with a septum. So you go all the way up to cut the vaginal septum, and then we go to the cervical septum. This is now the cervical septum, all the way up. And now we are in the uterine septum. Non-stop. And this is the tubal ostium here. It's a 12 minutes total reconstruction, vaginal, cervical, uterine septum. Look at this. So now this is the final view. Beautiful cavity, communication of two corneas, removal of the vaginal, cervical, and uterine septum. This is a case not related to fertility, but I want to show it to you. I promised you wonders, okay, Dr. Reddy? Are you ready? Say yes.
Yes.
Yes, okay. I want to see your smile, Reddy, okay? All right.
Okay.
Yes, show me your smile, please. Please. You are a nice man. And I envy you because I want to make a mustache like you, but I cannot, okay? I am a bald man. I don't have hair. All right. You should donate some of your hair to me. All right. So this is a vaginal fibroid. Can you imagine? This is the hymen. This is the hymen ring. All right. This is a fibroid in a patient in a virgin. So in my country, Fessi, you cannot sacrifice the hymen. So I went trans hymen. And do slicing of the fibroid. This is the vaginal rouget, and this is an intravaginal fibroid. And here is the hymen. So you are working just above the hymen. So, well, what about hysteroscopy and the fallopian tube? There are so many cases of subtle pathology near that ostium, which cannot diagnose by any method of investigation, like this one. This is a polyp obstructing the ostium. So this patient was advised for IVF because she was diagnosed tubal obstruction. So instead of paying $3,000 for Fessi Lewis to do IVF procedure, I can do it only by hysteroscopy for 2,000 rupees only, okay? So this is one of the advantages of hysteroscopy, to diagnose a pathology near the ostium. Also, you can do nice tests. Look at this test. Tubal patency test by bubbles. Look at the bubbles. This is ostial dilatation. Look at the bubbles, Bessie. This tube is obstructed. The other tube is patent. You see the bubbles are going. So the advantage of hysteroscopies are unlimited. I have two pathology to speak about Asherman. It's a nightmare. I am very glad to share with you a case I did with Dr. Brajbala Tuweri in Life Care Hospital in the city of Indore. Fessi, I visited every corner in India more than you. I have seen every city, every village. Even I operated in an area they don't have electricity. We are working on generators, okay? So this is a case of no cavity. Dr. Brajbala Tuweri, she's a wonderful, wonderful doctor, and I love her family, her husband, Dr. Sunil, and they invited me 5-6 times. So she presented this case to me as a zero cavity. And you can call Dr. Brajbala and ask her. This patient was scheduled for surrogacy. But when I visited them, she said, Osama, why don't you try to enter the cavity? The cavity was totally glued. Look at that. The cavity is totally glued by adhesions. Everybody enjoy the beautiful technique of hydrostatic dissection. Look at that. Gradually, release of the adhesion. Look at this. Look at that. Beautiful. More relief. And there is some clue here. Look at the beautiful dissection. And now we could reach one ostium. One ostium is reached. Let us now search for the other ostium. Cassie, look here. Look here. You will see a miracle now. Miracle. Look here. Oh my God. Jadugar, Jadugar. Okay. This is the other ostium. You will see it here now. This is hop. This is the other ostium. So beautiful. Reconstruction of the cavity. And after that, we did a PRP. This is the PRP. This is before and this is after. And this patient had successful pregnancy, IVF, twin baby boys, and it was the talk of all Indore city about the Jadugar with the stick. People think that the hysteroscope is the magic stick. Okay, let me finish now by last two cases. What are the role of hysteroscopy for fibroid and polyps? Definitely, any pathology inside the cavity will affect fertilization and implantation. Let me show you one of the beautiful procedures. It is a combined polyp and fibroid. Fessi, polyp and fibroid. And you will see the video non-edited. How much time you think? 2 minutes. So it was mission impossible. Oh, where is the video? Are you ready for mission impossible?
Yes.
That's the polyp. Non-edited total time, 2 minutes. Finished. Polyp finished. Now the myoma. Now you can see the myometrium. This is the myometrium, the basal myometrium. This is the myometrium. And now enjoy this step. Backhand. Finished. Let us check bleeding. Bleeding. Put our eyes. Put our eyes. And this is Mission Impossible, Tom Cruise, James Bond. Are you jealous, Fessy, or no? Well, I just want to entertain you and to prove to you that this magic stick can do wonders inside the uterus, can make the cavity much better to receive the embryos. The last case I'm finishing with you, this is the last video before I say goodbye, just to show you nothing is impossible. You know Dr. Anu Agarwal. What is impossible? I am possible, okay? Show me your beautiful smile, all right? I love your glasses, okay? When I come to India, I want the same like yours, all right? Okay, so this is a case of a type 5, type 6 myoma. It is not inside the cavity. So this is classic for laparoscopy. Hello, Vandana, how are you?
I'm very fine. It's so nice to
miss
have
you very much, Vandana Bansal.
Yeah,
I miss you.
yeah. I miss
Well,
you too.
Okay, so this is the case of a type 5 fibroid, which is not inside the cavity. This is easy game for laparoscopy, but nothing is impossible. I will share to you how to reach type 5 myoma, which is not bulging into the cavity. So Fessy, focus with me. Now, cutting into the fundus, trying to reach the high up myoma. It's intramural. Cut, all right? Cutting into the fundus until you see the shadow of the myoma. Fessy, do you see the myoma now? It is behind this thin capsule. How to identify the capsule? This is the capsule. You see it, Fessy? Fessy, do you know Victoria's Secret? Victoria's Secret.
Yes. Yes, sir. Yes, sir.
Very thin capsule, right? And now you can see the myoma. This is the myoma, right? But it is still not inside the cavity. So you have to bring it down in the cavity and then do resection. There is no myoma screw for hysteroscopy. But here, I use laparoscopy myoma screw. This is a laparoscopy myoma screw. Side by side to the hysteroscope. Screw the myoma and pull down. I want to deliver the myoma inside the cavity. Screw and pull. Screw and pull. Now the myoma is getting down into the cavity and become more loose. You see that? Now the myoma is inside the cavity. Screw and pull down. After that, myoma resection was done. Enjoy the final view. This is the cavity of the fibroid. After the fibroid removed, we have the beautiful cavity, this tubal ostium, and this is the myoma removed from here. So myoma was removed from here, but I cannot take sutures like laparoscopy. Look, when you decrease the fluid pressure, the edges come opposite each other. You see that? So after screw, bring the myoma down, resection, and then when you finish, this cavity will collapse, edges will coapt, and complete healing occurred in like 3-4 months. And this lady also had a successful IVF and pregnancy with also twin girls. So this is the beauty of hysteroscopy, that can does miracle inside the cavity. It can correct anomaly. It can remove fibroid, polyps, treat chronic endometritis, inject PRP, prepare the cavity, remove the adhesions, and enjoy higher success rate in your assisted reproduction. And by this, I'm happy to say it was lovely to see you all. And I can leave you now to go to my operating room, because patient under anesthesia since 20 minutes, all right? I love you all. I miss the lovely memories with all of you. Thank you, Fesi. Thank you, Reddy. Thank you, Bansal. Thank you, Dr. Agarwal.
Thank you, Dr. Sama. It was lovely and mesmerizing.
If any questions, we can do it quickly if you like.
Over to chairperson. Before that, I just want to know, you just show about the adhesion removed by the hydro dissection. So what is the pressure inside of the fluid inside?
Fesi, you are a devil, okay?
No, just to know, because
No, because you know that the pressure issue is the problem of my life, okay?
We wanted to use that, how much pressure we have to achieve that.
Listen, Fesi, for laparoscopy, the pneumoperitoneum is fixed number 15. You don't change. Whatever the kind of surgery in laparoscopy, you don't change the intra-abdominal pressure. But in hysteroscopy, you are facing so many challenges. Number one, the cervix is leaking, all right? The tubes is leaking. The size of the cavity differ from one patient to another. So the number of the pressure, I cannot tell. It depends on how much you can distend the cavity. Sometimes if a cavity very, very small, a pressure of 100 is enough. But a big cavity and tough adhesions, I can reach up. Please understand what I say. When I say the pressure from the pump is 300, this does not mean that the pressure inside the uterus is 300. This is very important information that unfortunately people were not aware about. They said Osama is crazy, he is using high pressure. And this caused a lot of troubles to me. No, the pressure in the pump shows the pressure coming from the pump. But inside the uterus is different. It could be 300 from the pump and inside the uterus 80. It depends on the leakage. So my advice to you, you go inside the uterus with the pressure starting is 100, okay? If you find this enough, continue. If you find that the cavity is collapsed and there is no push, increase more. Like you're driving your car uphill. If you tell me, Osama, how much I press on the pedal of my car, it depends on the slope of the mountain.
Yes, sir.
But in this particular case, I was using a pressure of 250.
Okay, thank you, sir.
So it was a wonderful lecture. So I just want to know one thing. And in the last video you showed, intramural myoma, you removed through that screw. Sir, have you ever encountered any case of uterine rupture? It was like, it was high up in the myometrial cavity and then you pulled up that.
Listen, my friend, when fibroid grow inside the myometrium, the myoma expand and push the muscle fibers, okay? Push the muscle fibers. When the myoma is extracted, the muscle fibers remodel back again. This opening will not stay like this. There are remodeling of the muscles and then, but definitely we are a little bit cautious. When the patient got pregnant, we delivered her a little bit early, like 36, 37 weeks.
So there is a Dr. Sharma, excellent. And one thing you taught us, the scissor is not the instrument for cutting, it is to feel and it is to measure. So this is something we really get from the genius. There is one question from Dr. Kavita is from Tamil Nadu, and her question is, after lateral metroplasty in that endometrium, what you do to prevent adhesion, and how long to continue the medication to prevent adhesion?
Thank you very much, Dr. Gupta. Dr. Kavita from Indore.
From Tamil Nadu, Dr. Kavita S.
Okay, because I have a friend called Kavita. She has a center called One Day Hysterectomy Center. So I don't know if she is the one or anyway.
She is not.
She is not the one day hysterectomy, all right. So this is a very important question. What is the post-operative management after the septum surgery? Because there were so many advices. My comment, no balloon, no intrauterine device, no gel, no hormones. The epithelium will grow spontaneously and cover all this area. If you put a foreign body, like a balloon or a IUD, it will compress on the endometrium, it will delay the healing, and it may be a source of infection. So healing is perfect. But in Asherman, it is different. In Asherman, we do everything. Gel, balloon, estrogen, we give everything in Asherman. But septum, no.
Okay,
Thank you.
that was very, very informative and excellent presentation. It is always very mesmerizing to see you and hear you, see your surgery.
Vandana, I remember you very well. Very well. I remember you very, but I forgot, where is your city? Where do you stay in India? Which city?
Prayagraj, you have to come to the Mahakumbh. It's
No,
Allahabad. Yeah.
I am sure I know you well.
Everyone.
I met you, but I forgot the city.
Yeah. Prayagraj, Allahabad, where the Kumbh is happening. And
Allahabad.
you came to my
Allahabad.
hospital.
Yes.
Yeah, Allahabad.
Yeah.
Yes.
Yeah, I remember
Yes.
now. I remember. And
Yeah.
you have a very beautiful staff of nurses. They gave me flowers. Yes, I remember.
Yeah, sir. So very, very great.
I want to say before I leave, thank you very much for Mr. Vikas Singh, because Vikas did a tremendous effort. I gave him hard time because we were communicating. I was in my surgery, and we fixed it to be in time. So that's great. Thank you, Vikas.
Thank you.
Thank you, sir. Thank you for
very much.
joining in from your busy
Thank you.
schedule. Thank you so much.
Bye-bye.
Thank you, sir.
Goodbye, sir.
Hi, sir.
Thank you.
So over to Chair Dr. Anu.
Yeah, Dr. Fessy. So I think it was such a mesmerizing lecture. So we heard two lectures from the two legends, and we all cleared our doubts about this endometriosis and the hysteroscopic. So many, I think we are going home with so many take-home messages, how to cut septum, and like how many millimeters we have to cut, and the size of scissor blade is 3 mm. So we have to take care of how much we are cutting. Thank you. It was a wonderful session, and thanks a lot to our chairpersons. They made all the sessions so lively and interactive. Thanks a ton, and thank you, UNS team.
Yeah, absolutely. It's a very energetic session. Today's. Yeah.
So
Yeah. Shall I?
Wonderful to know that we have got nearly 750 logins today.
Thank you so much.
So
Thank you and congratulations.
Yeah. Nakul can give
Shall I proceed with the thank you note, Doctor?
Yes.
Yeah, thank you very much. Thank you. I would like to extend my heartful gratitude to our distinguished speaker. There's a lot of energy, lot of enthusiasm. Thanks to Dr. Osama sharing for immense knowledge and insight what he had given to us, and Dr. Paul for the contribution, and definitely means valuable contributions and regarding the evaluation of endometriosis. Thank you. I'm again grateful. Thank to Dr. Amit Patki, Dr. Bakshi, Dr. Ganatra, Dr. Anu, Dr. Fesi, and our chairperson for impactful scientific session. Thank you. Thanks for your support. It's invaluable to our mission, and let's look forward for many more engaging evenings together. Thank you very much, doctor.
So when we are having our next first Tuesday, next session,
Yeah,
Yeah,
sure,
we
ma'am.
can,
Sure, ma'am. Next
we can
Tuesday,
keep it
of
festive.
Feb.
Feb first week of Tuesday. That is
third Feb.
around, just see me date. It's around 4th of February.
4th of Feb.
4th of Feb.
4th of February. Just wanted to inform everyone that it's around, Facility sir has already informed that it's around 750 doctors login. And this shows that incredible turnout reflect the outstanding efforts of the conveners, Dr. Fesi and Dr. Anu ma'am, who is consistently bringing together esteemed faculty and thought-provoking topics that captivate and engage our audience each and every webinar. And we extend our sincere gratitude to the chief guest, guest of honor, and all the esteemed speakers and chairpersons for dedicating your valuable time and sharing your insights. Today's talks were truly engaging from both the speakers, that is Dr. Paul sirs and Dr. Osama sirs. Osama sir, literally, he was on patient, like he told me that he can't join. He had a patient around him, and then he joined at the end moment, and we are humbled for him that he joined at the end moment. And a heartfelt thanks to Dr. Amit Patkis and Dr. Asha Bakshi ma'am. And UNS is proud to contribute to such impactful academic events, fostering meaningful connections with the doctors and leader in the field of infertility through these vibrant platforms. And lastly, there is a Mahakumbh at Prayagraj, and I think Dr. Vandana Bansal ma'am has invited everyone, whoever is thought to visit their Prayagraj can definitely connect with Dr. Vandana Bansal ma'am, and she can help us to get the darshans and all the Mahakumbh enjoyment and vibrant vibes of this Mela. Yeah. Over to
Vandana, I'm coming on 19th.
Vandana ma'am has gone. He was
I think she has
also
left.
out. Yeah, he was also out somewhere, but she managed to join in for the webinar. Yeah. Over to you, doctor.
Okay, thank you.
Thank you all.
Thank you, Dr. Anu. Thank you, Dr. Fesi. Thanks,
Good
Dr.
night.
Pillai.
Good night.
Yeah, thank you.
Good night, madam.
Yeah.
Right.
RX1, can we stop recording?
Recording stopped.
Thank you, RX team. Thank you very much. Yeah.